So, hello Bilal,
Hi sir,
how are you?
it's fine sir.
So, very shortly we are going to receive one polytrauma patient,
Right, sir.
and are you ready for that?
Yes, sure sir.
And which approach you are going to adopt?
CABC
So,
approach.
please tell us briefly what are CABcDE.
CABCD approach is like C capital means catastrophic bleeding. Means
Okay.
Bleeding is uncontrollable, like imputation.
Life-threatening.
Life-threatening.
Right.
So we need to stop it immediately first.
Right.
Then we will move towards ABC. So A means airway breathing, airway maintenance and cervical
Yes.
protection. Then breathing ventilation. Number C circulation and hemorrhagic control.
Right.
Those are the three things that we need.
And D also.
D means,
Tell us D.
disability and neurological control.
Huh.
And E means exposure and environmental control.
Okay.
Yeah.
So here is the patient.
Right.
Right. So
Sure.
start catastrophic bleeding.
So
And
catastrophic bleeding is there.
he is bleeding from here.
Yes, sir,
You
sure.
can see.
Right.
So what do you do first?
So we need to put a cat tourniqueter to tighten up and to stop the bleeding first.
Right. So that is the CABcD approach. Very
Right,
good.
Right, sir.
Keep it on na. चलने दो
Yes.
bleeding को.
Yes.
So you can see.
We will keep tightening up unless until the bleeding will not stop.
Yes.
Right.
So cat tourniquet has been
Yes,
applied.
Applied.
Bleeding has stopped.
Right, sir.
So the catastrophic hemorrhage which he was having from the thigh has been stopped. Now what will you do next?
Now we will do the jaw thrust because he is groaning.
Because he is snoring.
He is snoring. And
Okay.
We will do jaw thrust first.
Listen to your trauma team leader first. What he is saying. Do the jaw thrust first.
So we'll do the jaw thrust first. Then in the meanwhile we will apply cervical collar
Okay.
to protect the cervical protection. Right.
So he is snoring because he is unconscious. He is
Exactly.
altered.
Actually.
His GCSE 9/50.
Right, sir. So we
Okay.
are,
So some problem with the sensor, but it's okay.
right.
So when you do jaw thrust, then so now his breathing has become clear.
Right, sir.
You can leave it. Now you can see Bilal.
Right, sir.
There was suction done, right? Just okay. And then what else you are seeing?
So I will say he is like.
Okay, his airway has been taken care of.
Yes, airway is clear, maintainable.
Yes.
Okay, then we will towards the breathing.
Yes, breathing. What are you seeing on breathing?
Ventilation, I am seeing just one side is elevated, right side is not elevated. The chest movement is not equal. Right.
So you mean to say, you speak slowly,
Right.
that there is a asymmetry in the chest rise.
Exactly, sir.
Right is not moving as much as the left, so there is a restriction of chest movement on the right side.
side.
And at the same time, what is happening to the neck veins?
Neck veins are dilated,
They are distended.
distended and dilated.
So in a patient of polytrauma, if the neck veins are dilated and there is a restriction of the movement on that right side,
Right side.
so what do you suspect?
So I say I completely suspect pneumothorax.
Tension
Like
pneumothorax.
tension
So just
pneumothorax.
palpate his
Yes,
chest. Maybe he has got some fracture.
I can do like chest compression test.
Ah, yes, do that.
So I will check it out. So I will see there is a multiple rib fracture, right? So I will see.
So
that
there
he
is something here.
Yes.
So he
is paining.
He's-
He's crying.
He's crying.
Yes.
So there is a definitely rib fracture and there are chances of tension pneumothorax. So what
Right.
will you do next?
So
Life-saving intervention.
I will go for needle
Needle decompression. Okay.
So Ravi will do needle decompression.
Okay. So that is the way.
Yeah, yeah.
Immediately we have to assess and resuscitate. So
Right.
he has got. So you can see that air. Okay. Now needle decompression has been done. So what will happen to his chest movement?
So
Let's
it will
see.
Start. Yes.
So now both the chest sides, they are moving equally.
Equally, yes.
So we have relieved the tension and his right chest is also moving up.
Absolutely.
Okay, so you have taken care of his breathing.
Right.
And obviously what we'll do after needle decompression?
Right,
Because
so we will move-
air will reaccumulate again.
Right.
What will you do next? We'll put a chest tube.
Chest tube, right.
Okay, so we'll put a chest tube, right.
Put the chest tube.
Okay.
So let us put the chest tube.
Okay, we will simulate like you are putting the chest tube.
Right.
Okay, what next?
Then we will move towards the C.
Okay.
Circulation and hemorrhagic control.
Okay.
So circulation we will see first. We will touch here all the extremities.
Suppose there are no peripheral vein available because I forgot to tell you his vitals when he came.
Right, sir.
His blood pressure was 110/70.
Sure, sir.
His heart rate was 140.
Sure, sir.
Respiratory rate was 34.
Okay.
So if you calculate his shock index, it is
It's
more than
more than
1.
one. Sure, sir.
So he is in shock.
Shock. Right.
So when your peripheral veins are not available, what will you do?
For IO access.
So you do IO access. Okay, so here he is doing IO access. So how will you do tibial
First
tuberosity?
also we feel the tibial tubulosity, below than tibial tubulosity, 1 to 2 fingers.
Yes,
on 90
1 to 2
degree.
finger. Show the 2 finger tibial tuberosity and 2 finger.
2 fingers.
Okay, so this is a used mannequin, but it's okay, but you can do.
Yes.
Okay,
On 90
do
degree with a slightly pressure.
90 degree. 90 degree karo na. Why are you tilting it? 90 degree. Yes.
Yes, sir.
Keep your finger away.
With a slightly pressure.
Okay, stop there when you get a give a feeling. Good. So let's see if you withdraw blood or not. Give him syringe.
Syringe. Syringe. Is the syringe? So it's good.
So that you are in the bone marrow, so you can start IV fluid with some pressure bag. Okay.
Yes, sir.
So now you have started IV fluid. You have taken care of his airway. His saturation is 96%. Right. But again, his blood pressure now with crystalloid, it came up to 140 by 90.
Right, sir.
Again, the blood pressure has gone down to 100 by 70.
Right, sir.
So what do you suspect in this
So I
patient?
suspect the bleeding inside.
Somewhere he is bleeding inside.
Sure.
So what are the common sites where in polytrauma bleeding take place?
Is a point of pelvic fracture might be there?
Pelvic might be there, hemothorax might be there. So if that is the X-ray, where is the file?
What is the X-ray? Show us.
So we'll just show the X-ray of the pelvis.
Right.
Okay.
And since the hemorrhagic bleeding is there,
But that has been controlled, na?
right.
So take करके दो. So this is the X-ray. What do you see here?
I see a fracture, sir.
Fracture of
I see a
the
fracture of pelvis bone.
where you feel
Well, I
see?
will see here.
Yes.
Yes. This is the fracture here.
Or pubic rami,
Yes,
multiple fracture.
pubic-
So maybe he is bleeding there.
Right.
What will you do now?
So I will do like I will see put the sheet
Pelvic
on
binder?
the pelvic binder.
Yes, we have pelvic binder. You can put. But if you don't have pelvic binder, then what will you do?
I
Keep
will,
you apply now. What are you
yes,
waiting
apply
for?
pelvic
See,
binder.
that is the problem.
Right.
When you have been given instruction pelvic binder, that means you concentrate on your job. You don't wait for anything else.
Right, sir.
So once it has been decided that pelvic binder is to be applied,
Right, sir.
then apply pelvic binder.
Right, sir.
No, they were distracted.
Right.
They were listening to us.
Sure, sir.
Stop his sounds now.
Sure.
So pelvic binder has been applied,
Yes, sir.
and again now his blood pressure is 120 by 80. His heart rate is 110.
Right, sir.
Okay, and so maybe he was bleeding from the pelvis. Okay.
So one more point. If the pelvic binder is not available, then we have a sheet to bind.
Okay, and where exactly you bind
Over the greater trochanter.
over the greater trochanter? So everybody knows that fact, that a pelvic binder has to be applied on the greater trochanter, and in my view, it has to be a rather greater trochanter binder rather than pelvic binder, because I have seen many times people are not binding over the greater trochanter, and that is of no use. Okay, so moving forward, now he is in altered sensorium,
Right.
right? So will you try to find out why he's in altered sensorium?
So
D.
I suspect I will check the pupils neurological
No, first you will have a head examination.
Right, sir. Right, sir. I will
Just see
have
if there is a head injury.
Right, sir.
Yes, sir. There is a head injury.
There,
sir.
there is
Be
a head
slow, na?
injury.
Why are you jumping on the patient?
Yes, sir.
There is a head injury.
There is
sir.
a head injury,
Yes, fresh head
and now
injury.
you will do GCS score.
Yes, I will
But we
GCS
cannot do
score.
right now because he is in altered. But why he is in altered sensorium, we know now because of the head injury.
Head injury,
What is his
right.
pupil?
Okay, I will check out the pupil. So the pupil size left side is dilated. It's not reactive.
Where is the left side?
Yeah, this is the left side. It's dilated. It's not reactive. While as the right side, it is.
Okay,
not
we can
dilated,
see
it
that
is
this-
normal. Yes.
Left side is dilated. So
Right.
because of the head injury, he is in altered sensorium.
sensorium.
Okay.
Right.
So what will you do?
So I will think about the CT scan. I will
Okay.
call the-
Once you stabilizes ABCD, and you also inform the neurosurgeon.
Neurosurgeon, sure.
Okay. So D is okay. He is in altered sensorium because of his head injury, and since his GCS was 19 by 15, so we did not intubate.
Right.
Okay. So what next? E.
And she's completely E means an exposure environmental control.
Right.
So we will explore. We will remove all.
Okay, we will remove. We have removed.
Just check it out.
And you do the log roll.
Yes. Log
Okay.
roll. Log roll. We will do log roll. Okay. They will help me to move the
Okay.
this body, like and I will check it out. Axillas, urogenital.
Yeah. Hidden areas. They're very important. Axilla and urogenital.
Yes. The positions like
Okay.
they can move.
On the count of 3, you will move the patient.
Yes. Sure.
1, 2, 3.
Slowly.
I will check it out. So there is there is one wound over there. In
Wound
back
is
side.
there, yes.
Sure, sir. So the private parts there doesn't seem any wound. Okay.
Okay.
So there is one wound behind.
3,
So that was-
2, 1.
And you will prevent hypothermia. So you will cover him. Please cover him.
Yes.
So this was a short demonstration how to take care of ABCD or rather CABCD protocol to be followed now in polytrauma patient. And with your management, now if we revise again, you have to keep re-evaluating the patients all the time, like after every 10 or 15 minutes. Now if I tell you the revised vitals, so his heart rate is 110 and his blood pressure is 120 by 80, his saturation is 98%, right? And he is stable for CT scan. So, and central line has been placed because IU access is only temporary, a time buying method, but you can keep up to 24 hours, okay? But still, we have got a central line, and as neurosurgeon says that his ABCD okay, you can send him to the CT scan. So, good job done. Thank you very much for your participation. And let me tell you, we have to iterate, deliberate. We have to repeatedly do ABCD, CABCD protocol. So iteration and deliberate simulation practice is the key to learn any skill, especially trauma. Okay, thank you once again. Thank you very much.
Thank you.